Good day, and welcome to Epstein Becker Green's webinar, Post-Acute Preferred Provider Arrangements, Strategies for Partnership, part of the Transacting in the Post-Acute Care Space Crash Course Series. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are also welcome to submit questions directly to the presenter following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have a fantastic speaker today. Clifford Barnes is a member of the firm in the Healthcare and Life Sciences practice in the firm's Washington, D.C. and New York offices, and serves as co-chair of the firm's Health Plan Compliance Group. Mr. Barnes has been employed by the firm for over 35 years and represents providers including hospitals, hospital systems, post-acute providers such as nursing homes, home health, hospice, and long-term acute care facilities. Mr. Barnes also works with managed care companies concentrating in Medicare and Medicaid and nonprofit associations. Mr. Barnes is the co-founder of the Medicaid Health Plans of America and currently serves as vice chair of the Accountable Care Organization Task Force of the American Health Lawyers Association. After receiving his MBA in Health Administration and before attending law school, Mr. Barnes served as a healthcare executive for 4 years. At this time, I'd like to turn the webinar over to Cliff.
Thank you. When I graduated from business school in hospital administration in 1974, the market was characterized by no competition, and fee-for-service was the order of the day. Fee-for-service in that time allowed providers to charge whatever they wanted to, and payers would pay. 43 years later, in 2017, competition is now the order of a day and consistently increasing. Fee-for-service, as we knew it then, has changed completely, such that providers now determine what is charged and pay that. And increasingly, payment is now moved towards outcomes. Consistent with this trend is preferred provider arrangements that we're going to talk about today. In fact, I think preferred provider arrangements will accelerate the process of competition, as well as the move towards outcomes for fee-for-service. And it pretends real winners and losers in the marketplace. On page 4, for providers, there are a number of reasons why hospitals and post-acute providers need a preferred provider arrangement strategy. First, we look at the future. MedPAC is consistently now recommending a unified payment system for post-acute, which would move payments from site of service to patient characteristics, which would incentivize efficiency and high acuity. What's interesting is MedPAC is now advocating that that be implemented in 2021, which is many years ahead of what was noted in the IMPACT Act. In terms of what the existing areas of course, the readmissions. While the Trump administration has been focused on knocking out the Affordable Care Act, they are promoting the penalties under the readmission reduction program, which are up to 3% of hospitals' payments as of October 2017. Based on the most recent data, of all of the hospitals that were evaluated for readmissions, 4 out of 5 of them received penalties. Also, the environment is now filled with bundled payment arrangements, which are increasing, as well as value and outcome-based payment arrangements. Just as significantly, these preferred provider arrangements offer an opportunity to gain more control over quality. Effectively, a virtual vertical integration without acquisition, time and expense, and without entering the business itself. When we talk about post-acute, what we're talking about is long-term care, inpatient rehab, SNFs, and home health care providers. From a payer perspective, they also, acute care, preferred provider arrangements also offer an opportunity for controlled costs and outcomes. If you follow the dollars, you'll see that from Medicare's perspective, out of all of the acute care discharges, 42% went to post-acute. And that 42% represented $60 billion of services for Medicare alone. The EBGA approach to preferred provider arrangements is an holistic approach that's really designed to look at the entire process. And in that regard, we have combined with EBGA Advisors, which is our captive consulting company, to develop a process which is a 7-step process, which is outlined on page 7. Now, don't confuse that with the 7 steps of AA. This is a different 7-step process. But EBGA Advisors leader, Bob Atlas, who used to be president of Lewin, the Lewin Group, as well as the COO of Avalier, and EBGA have come together to develop what we think is a comprehensive approach to development of preferred provider agreements, which I am going to summarize during the rest of our presentation. What's important here is that we're going to take an approach from a hospital perspective. However, post-acute providers can gain a lot of understanding about the process to better enable them to prepare for when a preferred provider arrangement comes to a hospital near them. Just as important is that based on the competitive marketplace, the post-acute providers can also enter and should enter this process wherever they are, so that in some instances, post-acute providers can approach hospitals. We have worked with SNFs as well as home health care companies to approach providers and develop preferred provider arrangements. So let's start with our 7-step process. The first step is the assessment process. This is how you begin to design your preferred provider arrangement. And the hospitals have an ability to design it. This is not a cookie cutter. You want to identify your needs, your pain points. You want to analyze your readmissions, look at the procedures which are causing readmissions, as well as the post-acute providers that are involved in your referral network. You want to assess your needs for the post-acute environment and include the issues that are important for you, including care transformation, which we're going to get into in step 4 and 5. What's important here is that the preferred provider arrangement should fix your issues with respect to readmissions, enable bundle payment, as well as increase your ability to enter into value-based and outcome-based arrangements. Step number 2 is to develop the data request and analysis. This should help to resolve the pain points that are identified in step number 2 and enable you to look at the capabilities of the post-acute providers, particularly in the areas for which readmissions are evaluated, heart attacks, heart failures, but it should be focused on wherever your points of pain are. Importantly, though, you also need to analyze facility leadership, the senior staff, employee satisfaction and turnover. This is a joint venture, a dynamic and evolving process, and you want to make sure that you can access the information so that you can make a determination that your partner will be dynamic and ability to evolve with the process. Step number 3 is the evaluation of the market area post-acute providers. This has to be objective criteria so that you can create objective data. This is important because this fits right into your ability to create your narrow network while providing patient choice. It's got to be based on objective data. You also want to use it as a time not to alienate, but bring folks together. So you want your case manager, your discharge planner to be involved in the process so their preferences are also taken into account. The bottom line is to create an objective criteria and also to be able to evaluate the commitment, the post-acute providers' commitment to collaboration and partnership. That is a key. Step number 4, select the network. This is a credentialing and re-credentialing process, but again, you have to set it for where you are. If readmission rates nationally are 23%, then the state is at 22%, and you're at 22%, then you may want to set your credentialing at 20%, and then gradually go down so that you are consistently moving forward with reducing that rate. But you have to set it in the market in which you're in. Hospitals also want to have the ability to suspend, which we'll address in step number 7, so that you want discipline in your network, and you want to make sure that you accomplish the pain points which we pointed out in step number 1. Number 5 is to redesign care to affect the care continuum. This is the transformation process that is also required for these preferred provider arrangements, because you have to create and integrate and coordinate the patient's journey across the post-acute continuum. The focus is to remove silos and to focus on person-centered care models, to transform the patient experience through integrating interventions. What we use is MedPAC's recommended strategies around communication and skills for the staff, as well as telemedicine, and importantly also the National Transitions of Care Coalition 7 essential intervention categories for care coordination and transition. This transition planning, information transfers with respect to IT strategies are critical, and sharing accountability across provider organizations so that you design the programs, and then, of course, we need to reflect that in the agreements, which we will address in section 7. Number 6 is to establish the means and measures of ROI for the acute and post-acute provider. You want to incentivize the conduct that you want to promote. You have to drive improvement initiatives. This is not a static process. Once you set it, that's it. This is a constantly evolving process of preferred provider arrangements. Metrics that measure effectiveness and ROI for the network, and again, network members that fail to maintain the metrics need to be suspended. Those metrics, there are several of them. A few of the examples are shorter length of stay, more complex patient mix, readmissions and root cause analysis, as well as outcome improvements around infection, pressure ulcer rates, falls, and the like. And then, of course, patient satisfaction results need to be consistent across the entire network. Number 7 is the actual development of the preferred provider arrangement. One of the key things is to establish the criteria that will enable the patient to make an informed decision, preserving patient choice while also promoting the narrow network. And this then ties back to the selection criteria. This, however, needs to be consistent with conditions of participation under Medicare. And those conditions of participation require that the list of SNFs be available to the patient, that the hospital document that the patients have actually received that list. They have to document that in the medical record. Also needs to be documented that you've informed the patient and the patient's family of freedom of choice. This also has to be consistent with not creating limitations or specificity around qualified providers and also disclosing financial interest. This next part of Section 7 is actually the 10 substantive points that we believe need to be in all agreements. Communication requirements, including education initiatives to improve the clinical skills. This is a ideal opportunity for IT interoperability to grow and develop. Monitor the requirements. Monitoring requirements and structure are key and ongoing. Again, here is the basis for suspension of network members. I think discipline is going to be very important in the network. The oversight structure, you know, how this entire process is going to be operated. Data collection process, again, the IT initiative becomes critical because it's a data-driven process. The credentialing criteria is also important and specified in the agreement. Discharge and post-discharge responsibilities for all the parties need to be enumerated. Care coordination, including transformation initiatives, also need to be described in the agreement, as well as metrics and measures for ROI. And we believe that incentive compensation makes a lot of sense when at all possible. What happens typically is for the skilled nursing facilities, reducing their length of stay means that they're going to be making less money. Many times that is addressed by increased volume. However, including incentive compensation where there's shared savings based on a reduction of readmissions also becomes a great incentive to incentivize the conduct that you want to promote. In summary, I would say now is the time for hospitals and post-acute providers to think about and prepare for preferred provider arrangements. Thank you.
Thank you, Cliff, and thank you to everyone who joined us. If you have any questions, please feel free to follow up directly with Cliff Barnes via phone or via email at cbarnes@ebglaw.com. This does conclude today's webinar, and approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.